which is October, and we have a few days left to talk about it. And of course, it's a very important issue for all of us to talk about all year round, especially, we're going to find out exactly who specifically needs to pay attention to Breast Cancer Awareness Month, who's most at risk. And we have Dr. Jim O'Toole from O'Toole Plastic Surgery back with us today on Liz Live to talk all about breast cancer awareness, the risks, the prevalence, and what can be done if you are so unfortunate as to have to deal with this issue. So welcome back, Dr. O'Toole.
Thank you very much, Liz. Appreciate it.
Oh, it's so nice to have you. So obviously, I think we've heard so much about breast cancer that I think when we hear so much about something, it almost becomes normal and we forget how important it is, even though we hear about it all the time. Oh, someone else will take care of that, or that's an issue we've been hearing about for a long time. But it's still really, really important. And I'm wondering if you could, maybe we can start by talking about the prevalence.
Yeah, so as with anything you hear a lot, people tend to get tone deaf to it. You hear breast cancer affects 1 in 8 women in this country, which is in fact true.
1 in 8.
1 in 8 has been the number here in this country for quite some time. And so if you think about it logistically, everyone that's on this planet that has a family and friends is going to have somebody that runs into breast cancer at some point in time. Mm-hmm. Someone that means something to you. It's virtually unavoidable. Mm-hmm. And so the thing we can't forget about is not only does it affect 1 in 8 women, but it affects the entire social circle of that 1 in 8 women, regardless of the age of the woman, her children, her husband, her friends, her families, her partner. It affects everybody within their social circle in some way or form.
It sure does. So, I mean, you get to see women, I suppose, at all stages. In other words, you might meet somebody right after they've been diagnosed. Is that correct? Like when you enter?
It depends, quite frankly. I can meet them the time they find out they have cancer. I can meet them just after they found out they had cancer and they're undergoing chemotherapy. I can find out oftentimes in younger patients that are genetically susceptible before they have cancer. I get a lot of those patients. So we see them, and then we see a lot of them actually after the full treatment when they're unhappy with their results and they can't wear a bathing suit or a camisole, or they look down in the shower and they're not pleased with what they see.
Yeah.
We see a lot of those patients, and frankly, there's a lot of things that you can do to improve the look, shape, and contour. And the 1998 Women's Health and Cancer Recovery Rights Act allows a woman to have any and all surgery, and it has to be covered by insurance. So if there's a form problem that prevents you from wearing a bathing suit or a summer dress to a party or a tank top because you forgot something when you went to the grocery store, there are ways to improve and fix that, and it's a federal requirement that insurances cover it.
So if I go have my surgery and I hate the results, I can come to you even 6 months later and say, hey, I don't like this result?
You can come to me or any other qualified plastic surgeon 16 years later and say, I'm not happy.
Okay.
Yeah.
So when we're thinking about prevalence, is there a specific, because I know this probably changes over time, but is there a specific age, a specific, environment? Is there a specific, we know women, it's more prevalent in women, though I know some men do get breast cancer.
Of course.
So who's most at risk?
So that's a very loaded question. The people that are most at risk are the genetically susceptible people. For example, the BRCA1 gene is by far the highest susceptibility. But susceptibility is graded, and BRCA1 and BRCA2 get all of the heavy press. But there's PALB2, there's STK11, there's CALDN, there's CDK. I mean, there are an entire litany of genes that are tumor suppressor genes that lead to increased risk. So if someone has a strong prevalence in their family, multiple breast cancer patients within a single family lineage, perhaps ovarian cancer or melanoma or pancreatic cancer or colon cancer or sarcoma, there are a lot of genes out there. P53, for example, is associated with sarcoma, breast cancer, and hematologic malignancy. So if you see that trend in the family, that person has to get genetically screened. Outside of the genetics, there's a couple basic simple rules or simple things that increase your risk. The increased number of periods a woman has in her lifetime increases the likelihood of breast cancer.
Really?
So early menses, late menarche, lack of pregnancy all increases the number of menstrual cycles.
Okay.
Because every time you have a menstrual cycle, you have the proliferative and growth phase on the front end, preparing the endometrium and the breast for theoretically getting pregnant. Well, then those hormones go down. So it's an on and off cycle, on and off, on and off, on and off. And every single time you repetitively do that, you slightly increase your risk. Obesity increases the risk because fat tissue is actually a lot more biologically active than people think. It creates an estrogen analog called estradiol that actually is very estrogenic. So there's an increased risk in obesity. There's an increased risk in people who are very sedentary. One really peculiar thing is if you look at the risk in the United States, it's roughly 92 out of every 100,000 people. If you go to Central Africa, it's 26, 27, 28, it's much lower. But if that person immigrates to a place where breast cancer is much more prevalent, like the US or the European Union, within 2 generations, that family assumes the risk where they moved. So that suggests a strong environmental component as well.
Wow. And what about, like, when we're talking about environmental, it could be, the actual environment around you, but it could also be foods,
diet, exercise, lack thereof. As mentioned, obesity is a significant driver of multiple tumors, not just breast cancer, colon cancer, pancreatic cancer. So that is in part of the explanation. But could it be refined foods and a poor diet on top of it? Most likely, yes.
Do you believe, because I know I've read a lot of articles about the some of the chemicals and hormones that are in our produce and in our meats, do you believe that could have possibly a role?
I don't think that has as big a role, because if, for example, if you're using hormones in the animal, the hormones in the animal cause the animal to grow. But hormones, by virtue of how they work, are very short half-life. So it makes the animal grow faster, but that hormone's not present in the meat when you eat it, for example, because that's just not how hormones work. So could there be a slight causality? Yeah, it'd be hard to prove, but the reality is most of these hormones are very short-lived in the system, regardless of the animal. So it's probably the fact that we don't eat the way humans were meant to eat, rather than hormones. If you think of the first several million years of humankind, you ate what you could collect, dig up, or occasionally hunt. You didn't eat a lot of meat, because if you're going out to try to kill a very large animal with a stick, chances of you being successful are very bad.
That's right.
So early humans, for the first several million years, ate what they could collect. They didn't know how to cultivate land initially. So only over the last couple hundred years have we had food preservation, and over the last 100 and change have we had refrigeration. So now we can eat whatever we want, whenever we want, and there's more red meat in a grocery store than most humans would see in an entire lifetime. And so what we're eating is not physiologically what the human body evolved to eat, and that's a big problem, and I think that's probably the real driver.
That's so interesting, So, who is the person, or what would make me say to myself, hey, you know what, I should go get all of the genetic testing? So, for example, if I use myself as an example, my mother died of lung and brain cancer. Her sister died of cancer, but by the time they discovered that, it was too metastasized. So she died 57.
I'm sorry to hear that.
Yeah, and there's been a lot of cancer on my mother's side, not at all on my father's side. So would I be a risk?
When you look at cancers like that, for example, lung cancer, and when your lung cancer gets out, the first and foremost question is, was the person a smoker, or did they have environmental exposure? And then you look at the types of cancer and personal choices with that. For example, if someone has renal cell cancer or bladder cancer, they're almost always a smoker. If they're not a smoker, that tips something off. And so you look at the number of first-degree relatives within a family. Is there a cluster of breast cancer or ovarian cancer? That highly suggests BRCA2. Is there breast cancer and melanoma or colon cancer? BRCA1 goes higher on the list. Is there sarcoma, hematologic malignancies, and breast cancer? That's P53.
What does that mean?
It's a tumor suppressor gene. So BRCA1, BRCA2, PALB2, STK11, P53, they're all tumor suppressor genes. What they do, their job in the genetics of the human is to see a genetic mistake made and correct it before it propagates. And when you have one of these suppressor genes, when you have the abnormality, you no longer have the body's ability to be surveillance. So you have this DNA mistake when cells are dividing, and there isn't a system there to check them anymore. And so that is, in a nutshell, why people with the genetics are at increased risk of whatever cancers are associated. And that's where seeing a genetic counselor would be phenomenal for anyone who has that risk, because they know far better than I do all of the litany of cancers and associations. I know a large number of them, but the reality is there are people who specialize specifically in cancer genetics.
And how do we get to those people?
Bigger cancer centers. Like in Pittsburgh, AHN and UPMC both have big cancer centers. They both have very well-versed cancer geneticists at Hillman, at McGee, over at Allegheny General. And so all you would literally need to do is do a quick Google search and a phone call.
So if somebody's watching us right now and they're listening and they're identifying with what we're saying, they can just call down to UPMC or Allegheny.
You could even
Health
call
Network?
your insurance company and say, connect me with the geneticists, and then you can literally call them on the phone and tell them your family history, and they can literally tell you over the phone whether or not it's appropriate for you to come in and get tested.
So it's that easy.
Yeah, it's because it's so prevalent that the systems have gotten pretty efficient.
Wow. I mean, I'm so glad we're talking, because I didn't know that. I'm going to call today. Thank you. But I mean, that's why I think it's important to do these shows, to get this kind of information out that probably most people don't. I did not know that.
Well, this is a huge point of contention for me. And when I say this, I'm not knocking motorcycle riders.
Yeah.
But when you're in your car in the summer, you hear those public service messages, look alive for motorcyclists, pay attention to motorcyclists, because if a motorcycle goes against a car, bad things happen. Everybody knows that. It's a public service message. You hear it every summer. 1 in 8 women get breast cancer. When have you heard a public service message funded by our tax dollars actually informing people of these risks?
Never.
We know they're there, yet it's not done. And it makes no sense to me. All you would have to do is say, 1 in 8 women get breast cancer. If there's a system of cancers within your family and there's multiple cancers, you might be at risk. Make a phone call.
Yeah, I mean, it's so simple.
In particular, with a public service message like that, you may actually tip more people to do self-breast exam, get their mammogram done, or get the appropriate evaluation, and then actually solve a problem before it becomes a major problem.
Yeah, that's true. So that might take us into the, talking about screening, because I know this is so important, and I feel like, as a 44-year-old woman, you hear it for years and you hear it over and over again, but as you said, you almost become tone deaf to it. So how important is it to screen yourself, every month with the self-breast exam, and then to also get a mammogram every year?
It's critically important based on age, family history. Self-breast exam, we know from multiple studies, women that do self-breast exam diagnose in breast tumors sooner than women that don't.
Okay. And
if you're relying on your OBGYN, who you might see once a year, that's an 11-month and 29-day gap where no one is paying attention to the parenchyma or the chest. So that's important because early-stage breast cancer is depending on the biology of the tumor. But early-stage breast cancer has a 5-year survival of over 90% for stage 1 and stage 2.
Okay.
You cut that by more than half if it's stage 3 and 4. So if you catch it early, all things being equal, you're going to be better off. Now, the reality is with breast cancer and all cancers now, tumor biology is as important or potentially more important than the stage 1, 2, or 3 designation.
Okay.
Basically, the analogy I use with patients in the office, if you're going into an alley and there's a rabid Rottweiler that hasn't eaten in a week and you don't have something you can climb on too quickly, this might be a bad outcome, right?
Yes.
If you walk into the same alley and it's a rabid Chihuahua that hasn't eaten in a week, you probably would have sore ankles, but you
can shake it off.
But by terminology, they're both dogs.
Got it.
But one of them is extremely dangerous and one of them is not. The same can be said for breast cancers and most cancers, quite frankly. The biologically very active and aggressive tumors are the Rottweiler. The garden variety ductal carcinoma is the Chihuahua. It has to be addressed. You need to do something about it, but you're going to be fine. Okay. The really biologically active tumors, they behave differently and they behave poorly.
Are you seeing more young people being diagnosed before? Because when I was growing up, my doctors used to say, don't wait till you're 40 to get a mammogram. Don't worry about it,
There does seem to be a trend, a fairly consistent trend towards earlier age of diagnosis. So in this country, the average age of diagnosis is still 62.
Okay.
But there is a trend towards earlier diagnosis. Is it because we've discovered all these genetic traits and we're looking for it? Possibly. That's what we patted ourselves on the back for a while and said, but that doesn't seem to hold water to the heaviest researchers. So there does seem to be a trend. Is it that contribution of lifestyle and everything else, is that leading to diagnosis earlier? Perhaps. So
yeah,
it's not a question that we can completely answer, but it's still staying 1 in 8. But the age of diagnosis is coming down slowly.
Because I feel like I'm hearing more and more young women in my office coming in with having the experience at 30-some years old of having breast cancer or having a sister or a best girlfriend.
22-year-old in my practice.
22 years old. Mm-hmm. Now, explain that. Is
genetics.
Genetics.
Yeah. Genetics and bad luck, honestly. But she's 22 and diagnosed, and I have several that are younger than 22 that are BRCA positive that are trying to decide what route they're going to go, because it's an extremely difficult decision to make at a young age.
Okay, so let's get into that, because I wanted to discuss that with you. Let's play it out. So we find out that, I have God forbid, I have the BRCA gene, right? And what does that mean exactly?
So BRCA1 and BRCA2 are both tumor suppressors on the 17th chromosome. And what they do is they correct DNA mistakes, to simplify it.
Okay.
So if you carry that, tissue that changes frequently, like the breast tissue with the menstrual cycle, is going to have, when our cells divide, they make mistakes, because there's millions and millions of cells dividing. They make mistakes. Tumor suppressor genes are part of the body's surveillance to, if there's a mistake, to pull it out of circuit and say, you need to go away. So if you have this tumor suppressor gene, you don't have the ability to surveil it. Your body doesn't have the ability to pay attention and go, oh wait, you shouldn't do that, so you're gone.
Oh, wow, okay.
So that's why their risk goes up significantly. BRCA2, its lifetime relative risk is probably around 60+%. BRCA1 approaches 100%.
100%?
Approaches. But no one, at this point, people get screened, they get tested, and they do something before it becomes a problem more often than not.
Does your insurance cover a test?
Yes.
Okay.
Yep. There have to be, so that's the other reason to call the geneticist, because they know the particulars. There's a certain number of first-degree relatives that need to be afflicted with the cancers that we're talking about, like breast, ovarian, or whatever. And if you meet the certain number of people, then insurance companies will cover it. If you don't, they won't.
Okay.
It's just...
And how much do you have any idea what they would...
I honestly don't. It's come down, but it's still a fairly expensive test. But it's come down a lot from several years ago. But that's where, if you have a family history, calling one of the medical geneticists and saying, my aunt, my sister, my mom, and my mom's sister had X, Y, or Z, and they can tell you unequivocally, yes, you're covered, come in and get tested and we'll talk.
Okay. So let's say, God forbid, I discover I have the BRCA1, which means it's approaching 100% likely that I would get breast cancer at some point.
Yep.
Who do I talk to after the geneticist? Where do I go to you?
You go to a breast oncologist. Ideally, you go to a plastic surgeon that does a lot of breast cancer work.
Okay. Because
there are some options on the front end, reconstructively, that may not be available if you come to the plastic surgeon late in the game.
Okay.
And the other thing is to get multiple opinions, quite frankly. You're making a decision that is highly impactful on the rest of your life. And I tell people all the time, and when I see them in my office, I'm like, I might not be your guy, and that's okay.
Okay.
Just make sure you get opinions and get multiple opinions, and don't ever take the first word you're given, because these procedures have finality to it. If you do bilateral mastectomy, you can't go back and say, "Oh, well, I didn't really like that."
Right.
So there is finality to these decisions, and some of them are protective. For example, if you're BRCA1 and you do bilateral mastectomy, you don't have cancer, you don't have to have chemotherapy. Theoretically, there's still about some people believe a 1 to 3% chance of developing it, because there's a little breast tissue left behind.
Okay.
But if you don't run into cancer, you don't have the chemotherapy, you don't lose your hair, you don't run the risk of the nerve pain, you don't run the risk. Women that have conventional chemotherapy for breast cancer have a 20-fold increase in the likelihood of hematologic malignancy in their life because of the toxicity to the marrow and whatnot. Mm-hmm. So if you do it on the front end and do the mastectomy and the reconstruction, you eliminate all those potential risks.
Okay.
And so that drives a lot of the trends now towards younger mastectomy patients, because younger women are just literally saying, I don't want to deal with that.
Right.
Like, just do it and let's move on to our next. And I've had patients that have set guidelines. Like, one woman in my office decided mastectomy at 30. She was having her ovaries taken at 35. Had her mastectomies, had 2 kids before her 35th birthday, had her ovaries out, and so now she has minimal risk for the BRCA2 profile. There's still other things she has to worry about, but greatly limited.
Okay, so the first step, I would definitely, recommend, ladies, if you're listening, to please, look for a plastic surgeon that specializes, like Dr. O'Toole. Go get that opinion, and you're saying continue on. You get more opinions from who? Other plastic surgeons?
Absolutely, because the thing is, with these decisions that are major lifetime decisions, the more informed you are when you make the decision, the happier you'll be on the tail ends. Especially, let's say, God forbid, something goes wrong surgically. If you only saw one surgical team and only got one opinion, first of all, you might not be getting all the options that are available to you. Someone may say, well, we can't do the cosmetic approach to breast cancer because they may not be comfortable doing it.
Okay.
That doesn't mean it can't be done. It just means they're not comfortable doing it. But as a person going through this, if you get multiple opinions, it helps concretize your thought process. So when you go through it, it's easier emotionally to rationalize if something goes wrong or what you look like afterwards, because you've actually done your homework. You've done your due diligence. Right. And so you can rest assured on the fact that you did everything you could for yourself. If you just take the first opinion and say, to hell with it, get this. Like, the one thing I tell patients in the office is once you hear you have breast cancer diagnosis, if you could take it out with a wooden spoon, the tumor would hit the floor before your phone.
Yeah.
But that doesn't work that way. And so our responsibility on the front end is if a woman gets a diagnosis, is take them down from making decisions out of fear, because that's what a lot of women do. They get told, well, you have to do this, we'll do it next Thursday, and they don't get told the other options. And they're afraid of the cancer diagnosis, so they say, to hell with it, let's do it. And then 3 years later, they got out of the shower and they're like, I'm not cool with this at all.
Yeah.
And then they come to my office and other people's office and say, well, I didn't even know that was an option. Well, it was an option, you just weren't told. So our responsibility as clinicians is to talk a woman out of a fearful decision and making an informed decision. And the way to get informed is read, talk, get consults, talk to people that have been through it, understanding your experience is going to be your experience and theirs is going to be theirs, and they're not going to be the same.
So is this a good place where you might send someone to a therapist like myself?
Absolutely. And
just say, maybe you should go see Elizabeth or go see whomever and just talk about it with her and read together, because it's a huge
front end, middle end, and tail end. We as a practice have gotten really good because we've done this a lot, and we can see where they're struggling and what's making them struggle. But I don't claim to be a psychologist or a psychiatrist, so if I have someone that really is struggling, the women that tend to struggle the most are the ones that try to fight the reality of the diagnosis, and they want to try to pigeonhole themselves back into their life before the diagnosis, which can't ever happen. It doesn't work.
Okay.
I tell people all the time, once you have the cancer diagnosis, even though you might be through all the treatments, it's part of who you are now and forever.
Yeah.
But the most important thing, as we've talked about before, is while the cancer treatment is going on, cancer and the treatment requirements write that chapter of your story. As soon as that chapter's over, you have to pick up the computer and you have to write every chapter after that. If you do that, you'll be fine emotionally, and if you don't, you're going to struggle mightily. It's just...
Yeah, and I'm thinking, also for women, in my age group and younger, it doesn't really matter, but, as you know, and, Katie, who's sitting here, we talked the last show about how important your body image is and self-image.
Absolutely.
And so when I think about, for me personally, if I even think about having my breast removed, I feel like I'm almost, it's going to sound silly, but I feel like I'm losing an arm, even though they don't really do anything like your arms and your hands. It's a part of it's part of being a woman. It's part of your sexuality, which is part of your marriage, which is part of having children, which is part of your whole family life, and you're the one who has to then look in the mirror and see what it looks like when you don't have them.
When you get out of the shower. I mean, intimacy is very difficult if you're not confident in your own form.
Correct.
And I have a patient she and her husband and their kids have now become friends of mine, actually. The woman was diagnosed very young. She was a genetic susceptible patient. We didn't know that before her diagnosis. Long story short, she had reconstruction, and her reconstruction was good, but she just wasn't content with it because she started as a 32-year-old, and then she's a 32-year-old with a reconstructed chest. And she was really struggling emotionally. I couldn't exactly put my finger on why. And then at one point in time, she let out that, and this was 2.5 years after we were done with everything, she was at her scheduled appointment, and she confided in us that she hadn't had her shirt off in front of her husband since the surgery.
Wow.
And they'd been together for 12 or 14 years. And I said to the woman, look, until you're willing to let go and embrace the fact that this is who you are for now, I'm like, you're never going to recover. And so literally I wrote on a prescription, get naked in front of your husband tonight. And I signed it and I handed it to her and I said, if your husband does not initial this, I can't help you anymore. I literally can't. I'm like, because you have to do some of it yourself. Mm-hmm. So she took it. They came in the next week. It was initialed, and they had like the most amazing evening of their lives.
Oh, that's so nice.
But it was 2.5 years of struggle before she finally let go.
Yeah, that's really hard because doing couples therapy, a lot of times I find after talking with couples, if they're having intimacy issues, most of the time it's because a woman feels so insecure about something on her body that she just avoids it. Yep. And so I can't even imagine how that would feel.
It's easier to avoid a problem than confront it.
Definitely.
And then from the husband side of things, they kind of walk on eggshells because they don't want to upset the woman, they don't want to upset the wife, they don't know what to say because you don't have a frame of reference. There isn't some class you take in college like how to deal with a woman who's going through a breast cancer experience. So you become afraid to say what you feel or want to say because you don't want to upset her, make her feel bad, or make her feel self-conscious. Or if you say the wrong thing, even though you don't intend to say the wrong thing, it makes her upset, and then she barks back at you. Well, you know why she's barking back at you. She's not content with what she...
Yeah.
So that creates a dynamic that's very difficult for everybody. So then the husbands sort of back away from engagement because they don't want to make her feel bad.
Right.
But then that hurts the long-term relationship because you're not engaging with each other.
Right.
And that's why I said you almost have to embrace the diagnosis and run with it. And if you do, the other thing I tell women when they're going through this whole experience, one of the things that's going to happen, no matter how strong you are through the whole experience, when all is said and done, all the treatments are done, you're going to have a holy shit moment where you just like, oh my God, and the house of cards collapses. Mm-hmm. Because through the whole process, you have this next study you have to do, then you have to take this medication, then you have to have this surgery, then you have to go see this doctor, then eventually all that stops.
That's right.
And a woman realizes, wow, this is where I am.
Yeah,
and I just did all that.
And you're not running on all that adrenaline anymore.
Well, and you don't have that. Collapse. You don't have that next step to look forward to. And look forward to is sort of a poor way to phrase it, but really, every woman that's going through it looks as the next step that's going to put this behind me. I'm going to be done with the. But as I said before, you're never done with it. Yeah. You just have to grab the computer and write the next chapter. You can't let cancer continue to write it. And that's where people like you come in. Like if I can't get the woman through that, if I can't get their family structure through that because I'm not trained to do that, I know how to do it because I do it a lot.
Yeah, I'm sure you do.
But it's not my inherent training. So there are times, and I know when I'm not going to be able to get through, I pick up the phone, I call you. There's another psychologist in the city that works really well. I prefer clinical psychology strongly over psychiatry in this setting.
Absolutely.
And it's personal bias, but you go to psychiatrists, they say, well, you're depressed. And
they're going to put you on a bunch of
Well, they say you're depressed because you're general medical condition, which is a diagnosis, and they write a prescription, and then you go. Well, for me, there's depression related to, or let's not even call it depression. Let's say there's a mood disorder related to
adjustment disorder,
an identifiable source or a non-identifiable source. If there's not an identifiable source, then medication's probably a good idea.
Correct.
If there's an identifiable source, you say, like, for example, if you're walking out the front door and you stub your toe on the same slate table every day, you know why your foot hurts that day.
That's correct.
So you move the slate table 6 inches to the right so you don't kick it every morning. Well, if you know why you're struggling emotionally, body image or whatever, you work on that and the inciting event, which is the diagnosis and the treatment thereof. And you don't just take a pill. You work through what actually led to this situation.
Right. And I think that's a hard thing for some people to conceptualize, but no couple ever got better because of a psychiatric medication. I can guarantee you that. And I think that sometimes until people come in and do the couples therapy, they have this horrible idea of what it's going to be like, and they think it's going to be, me diagnosing them and, writing down notes and making them feel uncomfortable, but it's as comfortable as the three of us are sitting here right now. It's no different.
I think the one issue that people have is if you're admitting that you're going to therapy or couples therapy or a psychologist because you're struggling with the diagnosis or the end result, it's almost an admission of weakness.
Yeah.
People perceive it that way. Like, I need to go to someone who's a specialist to help me through this because I can't do it myself. So you're sort of admitting that you can't do it yourself. Mm-hmm. Well, take that, put it under the carpet and say, you know what? I'm going to go to somebody that knows how to help me with this. Mm-hmm. Like, you wouldn't actually go to the mechanic down the street and say, I'm having breast cancer reconstruction. Can you hook me up here? You go to someone who's... You might
like that, but no, I wouldn't.
No. But you go to someone who specializes in dealing with the particular issue you're dealing with, which is the oncology surgeon, the breast surgeon, the cancer surgeon, the plastic surgeon, the oncologist, and then the therapist and or psychologist if you're struggling emotionally with the reality of what you went through. So, and the resources are out there, just it's just a matter of consuming them.
Yeah, and it's such a, like, what you do is so, it just walks over into mental health every time we talk. And I hope people who are watching see that there's so many different resources for you if you're, going through something like this. And something that, I think probably people are really curious about, I know I am, is what is breast reconstruction like? And what does it look like? How is it done? Could you explain that?
Yeah, I mean, it all depends on individual anatomy, tumor subtype, tumor location, so I tell patients this all the time, goal 1 through 5,000 is addressing the cancer, right? What I do is a window dressing. So there are cancers in some locations where a very cosmetically pleasing outcome is very difficult to achieve.
Okay.
And so it's important for those of us that do this for a living to tell a woman, because your tumor's right here, right on the skin, especially upper inner part of the breasts, that's a difficult place to have a very pleasing reconstruction because it's visible in almost all clothes types. So it's our responsibility to say, hey, it sucks, the tumor's here, it limits what we can do, but tumor location, tumor subtype, patient age, breast type. I mean, breasts are as individual as fingerprints, quite frankly. Some breast types are excellent for nipple-sparing mastectomies with direct implant, and it'll look like a breast augmentation. Some you simply can't do that. It's just not feasible.
Okay.
So that's where getting different opinions is important too, because if some surgeon's not particularly comfortable doing X, Y, or Z, they won't even offer it to you. And then you don't know X, Y, or Z is an option. And then you don't want to find out after the fact that X, Y, or Z was an option, just Bill can do it and Jack can't, or Tracy can do it and Susie can't. I mean, so you want to be sure that you have a rounded knowledge of what's available to you with your breast type, and then you pick what works best for you. Because what I tell people in my office all the time, I can tell you what's feasible surgically relative to your breast type.
Okay.
Obviously, the oncologist has the final say on all of it because they're the ones treating the tumor. I'm not going to try to coerce an oncologist to do something that's actually compromising the cancer care.
Okay.
But then once you're aware of the things, I tell patients literally all the time, I don't know what you do for fun when you leave my office. So I can tell you what reconstructive options are available to you, and then you pick the one that fits best into your life structure.
Okay. So if you have both, is it true, because I've heard that nowadays if you're doing the double mastectomy, if you're getting complete removal of both breasts, if I'm using the right language, complete, I'm not sure if that's appropriate or not, but you're getting both breasts removed, that in that same surgery you can have the reconstruction done. Is that true?
In many circumstances. Not all, but many circumstances. The other thing we need to address, and this is something that is a trend as well, it's also okay to have no reconstruction. A woman needs to be empowered and told, if you don't want to do it now, or if you're not sure what you want to do, that's okay, because the 1998 Women's Health and Cancer Rights Act says if you decide 6 years from now that you're not happy being flat, you can do what you want. Wow. But there is a trend right now for women saying, I don't want to deal with all the extra stuff, I just want to be flat. And that's okay too.
Yeah.
Because you can always decide 4 years from now. The thing is, you can't undo surgery. No matter what surgery you choose to do, you can't undo it. Implant-based reconstruction is by far the most prevalent because it is, relatively speaking, reversible. You take the implant out, you remove the extra skin, and you're none the worse for wear.
Okay.
The bigger flap surgeries are not reversible in any capacity, so if you run into a problem with them, hernia, pain, core issues, unfortunately you can't undo that. But the one thing I tell women when they come to my office, I'm like, the first and foremost decision that needs to be made is, am I going to do reconstruction at all? Because you're not obligated to. It's hard for most women to even concede not doing that.
Yeah.
But then I also tell them, like, if you look at the data that our society studies very intently, the women that have breast reconstruction after cancer that have consistently the high satisfaction scores are actually the women that have delayed reconstruction. Because you're going from a frame of reference, if you have immediate reconstruction, your frame of reference is my breast to the reconstructed breast.
I see.
If you do delayed reconstruction, it's no reconstruction to a reconstructed breast. You're going to be happier because the chasm between the two is vast. Now, that original study was done before direct implant styles of reconstruction really came around, and we started doing it in New York with our crew. We were some of the first in the country. At the time, it was called single stage, not even direct implant, because we did it in one stage. The terminology changed because usually there's touch-ups afterwards, so single stage is not totally accurate.
Okay.
But my group in New York started doing that in 2006, and people looked at us, 2006, 2007, people looked at us like we had 8 heads.
Because
we as a group, I sat down with one of the younger attendings, and we had a very young woman, very beautiful. I mean, she fits all societal standards of what beauty is.
Okay.
Whether or not we want to get into that conversation is another story. But she also was a BRCA2 patient. She had something on her right breast that we were concerned about in imaging. We tried to do biopsies multiple times, came back breast tissue. So we did standard mastectomy with tissue expanders, which is what I was taught to do. Like, this is what you do because this is what we're told to do. And, you were taught by a paternalistic society, plastics, that if a woman looks good in clothing or in a bathing suit, you've done your job. Well, that totally neglects the impact on the woman when she gets out of the shower.
Right.
So I went to one of the younger attendings in my group and I said, look, we have 20 or 30 incision patterns we use in cosmetic breast surgery to hide the scars from the woman's eyes. I'm like, we agonize about hiding the scar in the cosmetic patient. In the cancer patient, we don't do that at all. Why? And the reason I had that thought is I went to see this young lady, did the standard operation. She was in the clinic, had a gown on, I think she had her head down, she was softly crying, and I said, what's wrong? And she said this, and I said, what's this? She said this. I looked like a 14-year-old boy got attacked by a lion.
Yeah, I can't imagine.
So that kind of shocked my system, and that made me walk out of the room, and I was looking at the resident's computer because our program director made you put all the pictures on because a resident in plastic surgery will stay on a certain rotation for 3 months, then you move on.
Okay.
Well, Mrs. Smith doesn't move on, right? That's her life.
Right.
So I looked back through all the images and I realized with a standard mastectomy scar, no matter how good the reconstruction was, the apex of the breast was the scar. And then if you looked at the profile, the scar blunted the breast, so it didn't have good projection. And I went to one of the younger attendings and I said, this makes no sense. I'm like, if I was operating on her sister, who's a cosmetic patient, I would never put that scar there. But in her, this is what we do. And then I did some research after that because I was uncomfortable with how I made that woman feel. Now, granted, I was the fellow, not the attending, but I was involved in her care.
Okay.
And we took literally the picture and societal image of what beauty is, and we put 2 marring scars and an outcome that just was unsettling to her.
Yeah.
So then I did a little more research about that incision. That incision's been around since 1914 or 1915. And it's extremely useful because it allows removal of the breast, removal of the leftover tissue, and access to the lymph nodes. However, the primary mode of transportation in this country in 1914, 1915 was a horse. So we now have cars that drive themselves. So
right.
to me, it just made no sense. Now, there are times where that incision is required because of tumor location, comorbidities, like if someone's not healthy and surgery in and of itself is a risk, you want to do what is quickest to get rid of the tumor and cancer, and that incision pattern allows a good breast oncologist to do this very quickly. But that's not appropriate for a 22-year-old or 32-year-old or 42-year-old or 52-year-old. You also have to think about where the patient is in their life, right? A mastectomy in a 25-year-old is not the same as a mastectomy in a 75-year-old.
Oh, God,
and
no.
It can't be treated the same.
No. I mean, I can tell you, I'm just thinking as you're talking, I know I would be really devastated.
It's
I would
hard.
be.
The other thing I bring up to patients in my office is there's a figurine called the Venus of Holophils. It's from a cave that was inhabited by Germanic people 40,000 years ago.
Okay.
In it is this little figurine it's presumably a fertility figurine. It's a very stylized female body without a head, which is another story entirely, but
okay.
But she's got a very voluptuous breast. And so at the time, it's carbon dated to somewhere between 39,000 and 40,000 years ago.
Okay.
So it's a time when humans were simply trying to have enough food and enough warmth to survive to the next growing season. They didn't know how to cultivate land, didn't know how to build domiciles. So basically all they ever did was things that added to their actual survival. So to take your time to carve a woolly mammoth tusk into this figurine with very voluptuous chest suggests that the female breast is a little bit more than just an organ that feeds babies if they're hungry.
Mm-hmm.
And it's been an important part of female form since the dawn of time, quite frankly.
Yeah, and I think it still is.
I don't think there's any question of that. That's why when patients come to me and they're 4 years out and they're not happy and they're like, I feel badly even being here because I'm alive, I immediately stop them right there. I'm like, that survivor's guilt bullshit is not going to work. And the reason is, you shouldn't feel guilty that you survived. You didn't choose this.
That's
if
right.
you make a bad decision and you don't have a poor outcome, you should be happy because you made a bad decision but didn't get burned.
That's right.
This isn't a situation where you're making a bad decision. It's a situation where you got, I call it the tag you're it diagnosis. And the other thing is, be respectful to those that didn't have the outcome or the results that you did, both through treatment and otherwise. But understand you're still a woman who before this diagnosis had a different approach, right?
Yeah.
Humans have adorned their body since the dawn of time. So to accept a shape or form, and this is the other thing I speak with patients, especially in the revision, when you look at breast cancer care, we talk primarily about, on the front end, about clinical endpoints. What's the stage? Where is it located? What's the surgery? What medicines does she have to have? Does she have to have radiation? That's all well and good while cancer's writing the story, right?
Mm-hmm.
But after that, cancer's no longer writing the story, and now you have issues of quality of life. A woman can't wear a bathing suit, or can't wear a sheer top, or can't throw on a tank top or camisole around the grocery store because her form's off.
Mm-hmm.
Well, now you have that woman who has quality of life issues because her life is restricted. What she can wear is restricted. What she can do is restricted based on the surgical outcome. That to me is unacceptable.
It is, and I think you're right. It's okay to care about that.
Yeah,
it's okay. And it's not. I don't think it's shallow, and I think it's part of being a woman, and I think it's real. And I think most women would feel like they lost a part of themselves.
Yeah, and it's the one thing I always say is I don't want to trivialize and say a woman in the modern era can't handle a contour irregularity or problem, because they can.
They can.
But should you have to tolerate it? And
I don't think so.
And again, the toe stubbing analogy I used with a husband a couple months ago, he's like, I love her anyway, I don't want to do this. I'm like, she knows that you love her. You live together, you've been together forever. But she doesn't love the form she has when she gets out of the shower. And that's where I came up with the stubbing the toe analogy. I said to him, I'm like, if you go to work every day and your couch is just 6 inches too far over and you stub your toe every day, you're still going to make it to work. You're still going to say some expletive probably when you stub your toe. And you're going to continue doing it until you move the couch because you realize this is an annoyance. I don't want to do this every day. And he goes, oh, I kind of get it. I said, all right. I said, let's say you drive a really fancy Mercedes. Mm-hmm. And the right front quarter panel has a giant scratch and dent in it. And he goes, yeah. I'm like, it's still a really fancy Mercedes. It still goes from A to B. It still gets the same gas mileage. It still serves the exact same purpose.
But it's going to really get on your nerves.
When you look on the right front quarter panel, that big dent and scratch is going to bother you, and over time it's going to bother you more. I'm like, for women that have big, significant enough contour issues that they notice it and see it, it's like having a dent on a quarter panel of an otherwise beautiful machine.
So I think that's a good way of putting it.
You're just going to fix it, and then all of a sudden you don't look at it anymore. And so the other thing about human eyesight is really good at picking up asymmetry. That's actually one of our best traits. We're not as good as color, contrast, or distance as birds, but symmetry is something humans pick out very well, to the point where your eyes will actually be drawn to asymmetry, even though you don't intentionally do it.
Okay.
So a woman who looks down and has an asymmetry, her eyes will be drawn to the asymmetry. It's not that she's somehow vain. That's
really what she's saying.
Human vision does that, and it's almost unavoidable. And then once you're aware of a problem, you become aware of it again, right? And you don't just brush under the carpet because you can't.
No, actually you wind up hyper focusing on it. Yeah. I think. So okay, so I'm gonna switch in about 25 seconds with your lovely PA Katie, and what I want to get a little bit more into some of the mental and psychological issues that you guys deal with, and I know Katie's a big part of that. One of the things that I have seen in the breast cancer patients who I have had in here as clients is when we're talking about all of this, removal, reconstruction, etc. Those women who have a supportive partner in a stable marriage tend to do a lot better than the women who have a lot of marital issues. And I hope that men are watching this too and know what an important role they play in this whole process.
Yeah, that's why I refer to breast cancer as a social disease, as we talked about before, because 1 in 8 women will get it, but it affects the entire social circle.
It really does.
And women that have good, solid, ingrained support networks emotionally tend to do a lot better. That doesn't mean they always will, but they tend to, because they have people they can lean on, and they have people that have an understanding, and they have people that know when to give you a little space. Like, there are times in a marriage where just walking 10 feet away is beneficial to everybody. But you also have to know when walking that 10 feet away is no longer beneficial and you need to walk closer to each other.
Right.
So having that structure, when that sort of setup, when someone's struggling with something, is very important.
It really is. It really is. So, all right, I'm going to switch places, and I'm going to also be looking at our screen because I know we have some questions. So enter Katie. Katie Fritz.
Hi, guys.
Hi. So, Katie, talk to us about your role in working with all of the cancer patients that come in and see you guys.
Sure. So one of my main things I do at total plastic surgery is first I help them feel comfortable. I mean, the first time you're coming into the doctor's office with this new diagnosis can be really scary and intimidating. Mm-hmm. So our big thing is just, helping you feel comfortable, introducing ourselves, and then learning about you, learning how you got to this point and what your fears are, what you are looking for at the end of this, and then getting you in contact with different support systems. So that's how we start things out, getting you comfortable, getting you the support you need to go through this journey. And then, of course, preparing you for surgery, making sure you understand how to be in your best, most optimal health before going into surgery so you can have the easiest recovery possible. And then, of course, we do the surgery afterwards. We're there for all the post-operative visits, and I'm helping them with that too. But the big thing is support. I mean, we get these women in the different networks and groups, whether it's Facebook or Force or American Cancer Society, somebody that they can talk to help them through the emotional part of it. Because although, we're the clinicians, we can explain to them everything from the medical side, we ourselves haven't necessarily been through the cancer experience, so having them speak to somebody who has helps them. So that's a big thing, just making sure that they know that they're not alone.
Do you feel like because you're a female that when women are coming in, they feel maybe like they might open up to you in a little bit of a different way than they do to Doc O'Toole, maybe just a little bit?
Yeah, and I mean, that's just because it's woman to woman. I mean, you're talking about things that you wouldn't necessarily talk to a man about that you've just met for the first time. So absolutely. Plus with Dr. O'Toole, he's so busy and he's pulled in 1,000 different directions. He's not always there on the front line, with being able to answer the email or the phone call right away. So I'm usually, or Nicole, our nurse, is usually the first person that they talk to. So sometimes we get to know them because we have more communication with them more often. So they sometimes will just feel more comfortable for that simple fact because I've been able to communicate with them more.
Right. You're the person that's answering all their questions and et cetera, et cetera.
Yeah.
Okay. So what are some of the things that you see in the female patients from more of the relation, if anything, of more of the mental health relationship health issues? Like, what do you see when you are talking with people? And really, either of you can answer that.
I think the two biggest things you see are anxiety and uncertainty.
Fears.
And the uncertainty drives a lot of the fear, I think. So we try to spell out as much as humanly possible. This month through our practice Instagram, we actually have 4 patients who have volunteered to tell their story.
Okay.
And each patient is vastly different than the other, to give another resource for women to understand there are different experiences, there's different ways to go through this, but at the end you need to grab the bull by the horn, so to speak, and run with it. And if you do, you'll be fine. And as Katie mentioned, we have a team that's set up to be available at all times. And quite honestly, to her point, if I'm in the operating room at Shadyside or at St. Clair, I'm not immediately available to a phone or email. So my staff that we work very closely with, they're the front line. They're the first person people often talk to.
Right, and your staff is awesome. I know them all personally, and they're all amazing. So I have a couple questions just from some of the viewers. I just want to see if... Okay, what are your thoughts on prophylactic mastectomy?
It's a loaded question, but it's a good question. It depends on the independent risk factors. It depends on imaging of the breast. For example, if a woman has a fairly strong family history, but her genetics are negative, but she has extremely difficulty to image breasts, and she's getting frequent ultrasounds, frequent MRIs, frequent biopsies, that might be a situation where prophylactic mastectomy, even though they don't necessarily have proven genetics, they're behaving somewhat like a genetic with their family history, that might be a situation where you definitely consider it. Simply doing mastectomy for the sake of doing mastectomy, 12.5% of the population gets breast cancer, which means that much larger number does not. So if someone doesn't have discrete risk factors, the most common situation where we do a prophylactic on the other side, for example, is if someone has a low-grade tumor on this side, has very difficult to image breasts. They spend a lot of time getting ultrasounds, biopsies, and MRIs, which is very anxiety-provoking, very time-consuming. That's a situation where prophylactic mastectomy would certainly be reasonable to consider, and then I would send that patient on to one of the trusted breast oncologists who can then talk them through it further.
Okay.
And then, again, family history is super important in that.
So, okay, this is a good, interesting question. How do breast implants affect breast cancer, if at all?
They don't.
They don't.
The only thing breast implants do is they change the mammogram views, especially if someone does a breast augmentation, because the implants themselves are radio opaque, so they have to change the mammogram. It's called Eklund views. But implants in and of themselves have no impact on recurrence or lack thereof.
Okay, so we don't have to worry about that. These are some good questions. Besides self-examination, what are other indicators of breast cancer? If there are any.
If you've had any radiation exposure throughout your life, certain pesticide exposures it's been associated with. I mean, a lot of that stuff's been taken off the market, but, with some of our older cancer patients, that is something that we ask when they come in. Did you ever have exposure to any type of anything that could, increase your risk, whether it's pesticides or
ionizing radiation is a big one. Yeah. So people my age and above, mid 40s and up, if you had Hodgkin's lymphoma as a child, you got mantle radiation, which was central chest. They don't do that anymore, but that is a discrete risk factor for increased breast cancer. We have a patient that had a sarcoma on her shoulder that was radiated. She subsequently, 25 years later, developed breast cancer in the ipsilateral same side breast with no family history whatsoever. So to say the radiation was not a factor is I think, foolish. And then, like we talked about before, obesity is a risk factor. But the thing about most of this is early stage cancers, virtually all of them, they don't jump out and say, hey, look at me, I'm cancer.
Right.
That's why vigilance and meticulous follow-up with imaging is important, because with the overwhelming majority of cancers, unless they're in a bad place, you don't have symptoms until it's way down the line.
Right. Yeah, I mean, it's just, I'm learning so much from today. I'm seriously, I'm going to call the genetic counselor. That's a big one.
Yeah.
It's if you have family clusters, it is, and they, like I said, they know what the requirements are from an insurance side to even get tested.
Right.
And they can also, they're probably pretty well versed in what the cost would be. There are some people that say, I don't meet all the criteria, but I'm willing to shell out the money to get the test, just put my mind at ease. Because it's hard to say, but what's peace of mind worth? Knowing you're not a genetic carrier, if you have a strong family history of other cancers, might make you not unworried, but it's not at the forefront of your thought process.
Right.
And that's got value.
So, I mean, I guess screening, monthly exams, you're saying, like monthly,
Yes.
just self-exams.
Just to get more into the self-exams, especially for young women, because I hear this a lot, you have to get comfortable and know what your breasts feel like.
Okay.
A lot of women have fibrocystic breasts, or a lot of women have dense breast tissue. You have to know what your breasts feel like, so if there is a change, that you can appreciate that change. Because I'll hear women say, well, I didn't know there was a lump there. My breasts have always been lumpy. Well, you should know what those lumps feel like. You should be doing your exam every single month in the shower, arm up in the air, all the way into your axilla. I mean, you should be feeling everything and get very familiar with your body.
Yeah, and the other thing is self-breast exam, especially if your menstrual cycle is regular, should be at the same time in the cycle consistently, because the breast feels vastly different in mid-cycle than it does tail end of cycle. So I usually tell people the best time, if you can, is tail end of cycle, if you're consistent, and 300, because women that do self-breast exam feel nodules much faster and at lower stage than women that don't. Because again, if you do it consistently, you know what your breasts feel like. So you're going to have that one area in the upper outer quadrant that's a little firmer, it's a little glandular, it's a little cystic. You're going to know it feels like that. If 6 months from now you do the same exam and it doesn't feel differently, or it feels differently, you're going to know that. And then you're going to call the dogs and be like, hey, I need to come in. Your PCP, OBGYN, family doctor, or even a plastic surgeon, they're going to get you tested. Usually you should go through whoever your gatekeeper is for your generalized health, like your PCP, and a lot of women it's the OBGYN if they don't commonly see it, or your family practice doc. But then that starts the ball rolling. And it's important, because when you catch breast cancer early stage cancer tends to do better.
Yeah, right. I know, it's so important. So we have to make sure we do that. Make the call. If you feel like you are at a higher risk genetically, make sure you call your insurance company, call UPMC or wherever your insurance, in particular, directs
the definitive cancer centers. You ask for the genetic counselors, they'll give them to you. You get on the phone, and they're usually very accommodating. We'll say, tell me your family history, and they'll say, well, yes, you would qualify, or no, you wouldn't, or you're on the fence. Probably a good idea for you to come in for us to give a thorough evaluation of the entire family tree, and then they can tell you what the inherent risks are. And then that oftentimes, for women who aren't quite ready to proceed with mastectomy, for example, but you're at higher risk, so some of the genetics that aren't super high, well, they can get you in a high risk clinic where you're seen more frequently with people that deal only with high-risk women, right? So if you deal with someone who does a high-risk clinic all the time, they're going to be, all things being equal, they're going to be a little bit better at catching something earlier, because this is what they do every day. And so if you're a woman that knows you're at risk, but you're not ready for that leap of faith, because it is a very difficult decision, as we've talked about, then you get yourself in one of the high-risk clinics where the imaging is done, it's organized well. If the imaging is even remotely concerning, they get the imaging done more quickly than you would in the outside world, because they're already geared up for it. So that's an avenue for women who aren't quite ready to jump into that deep end.
And then, like we said, to make sure that you if you are going to consider it, that you talk to someone, a plastic surgeon, who can really talk to you about, what reconstruction is going to look like. And you two in particular are really good, I know, so good at talking about all those mental health and self-image issues with your patients that they would have to think about.
Yep. The other thing we do as a team is on the front end, we empower the women that we take care of. Be like, look, the 1998 Women's Health and Cancer Rights Act is a law. It's there. So if what we do and you're not 100% happy with, or there's shape or form that you don't like after we're done, you're not insulting me or our team if you say, I'm not really happy with this, can we improve this? Because we're not one of those teams that has this arrogance, like, we did it, you should be happy. But that's, I would never say that to a cosmetic breast patient. Like, well, it's good enough, you should be happy. So why would I say that to a cancer patient? So I tell all patients that I take care of, I empower them. Like, if there's something you don't like, or something that you see in a shirt, or something you see when you get out of the shower, you let me know. And if there's a way to fix it or improve it, I'll do it. And if there isn't, I'll also say, hey, I hate to say it, but that's really something we can't do much about, and here's why. Well, that creates emotional placidity for the woman, because she brought up the issue, she brought it to the attention of someone that's capable of addressing it, and then we explain why it wasn't something that could be fixed. Well, then you go, okay, like, it is what it is, I can handle it, because, or more likely, something simple like fat grafting can fix it. And you take fat from somewhere that you don't want it, and instead of throwing it away, you take it by liposuction, you use it to recontour that part of the breast the woman's not happy with.
Yeah, big deal.
So absolutely, it's a
awesome.
it's a 20-minute procedure.
Yeah. That's really incredible. It's amazing what you guys do.
I do encourage the people that are interested to look at the patients on our Instagram that have actually told their story, because they're all very compelling, and each woman had a very different experience and a very different reason why they had a different experience. Okay. But it can be empowering to people that might be going through something or might be approaching something and not know. It's some really wonderful women that were very honest and straightforward and tell it like it is. Okay. And that could help people going through this.
Yeah, and I'll make sure, after we're done, that I tag and post all that on my page too, so that everyone can find that information if they're looking to do that. So, I think in closing, my last question to you guys that I think is a really important one is, what about women who do not have health insurance and do not really have a lot of resources, and they might be watching, or might have a friend? What can we let them know what can they do?
So people that aren't insured, there are a lot of different ways to get your routine screening through the American Cancer Society, through the Komen Foundation. There's actually systems set up at all the institutions for people who aren't insured. The one thing I would tell people is, just because you don't have insurance, do not neglect the serial evaluation and imaging requirements, because the last thing you want to do is be confronted with late stage. So call around. Like I said, the American Cancer Society has a big fund. Komen Foundation has a big fund. All the institutions have situations set up to take care of people that need care but can't. They have social workers that can expedite the acquisition of, say, Medicaid if you qualify, or one of the insurance equivalents. And once you're qualified for an insurance equivalent, even if you don't have it, the hospitals will start treating and start taking care of you.
Okay.
So don't let a lack of insurance be something that stops you from getting the care you need to save your life potentially.
Yeah.
And the last thing you want to do is then get to the point where you have to start getting treatments, but you haven't even started the ball rolling towards acquiring insurance. So, and the social workers at the hospitals can direct you, they can help you. And like I said, there are charitable funds for mammograms for women who can't afford it, for serial yearly exams for women who can't afford it, biopsies. There are things in place, and people should take advantage of it.
So all is not lost. If people, and what about, I don't know if you can answer this or not, but what about the reconstructive piece? What if they don't have insurance and they're going through this and they go to you or another plastic surgeon? Are there any options for them? Would you say the same?
You would want to probably go through one of the institutions, because they're set up to actually get insurance. Because the one thing, when you're at the, say, revision reconstruction, that is not deemed a life-saving thing, so the hospitals, they won't necessarily fund that, or they won't get behind that. But the life-saving front-end stuff, they will. But when you get involved, then you can talk to the social work teams, and they can say, hey, you're eligible for this or a gateway or whatever. And anybody that does a lot of cancer work accepts basically all insurances, unless you're in two institutions that don't like each other.
Yeah, sounds right.
But you never. I don't think it's appropriate for a woman to be wildly unhappy with her form just because she doesn't have a card with 18 numbers on it.
Yeah, I know, and it's something I'm seeing more and more of. Lack of insurance or bad insurance, or
and the fear of financial ruin.
Exactly. Exactly.
The higher deductible plans have made it harder for women. I think that was a big mistake when they changed the healthcare law.
Yeah,
passing larger deductibles on to people basically forced them to become consumers and not patients. Like, they're choosing not to do something that's going to make them happy because their deductible is $3,500. Well, why the hell does a woman have a $3,500 deductible in the modern era?
And that's a small one. I've heard all kinds of craziness.
The average right now, average as of last year was $3,500, and it goes up every year 5 to 7.5% roughly. So, and I had patients with $7,500 deductibles, so we squeeze things in before the end of the year just because they've met their deductible through their cancer treatment and they don't want to have to.
Right. Yeah, it's rough. It's rough out there.
No doubt.
Yeah. So, all right. So I'm going to switch around and say goodbye and wrap it up. Thank you so much, you guys. This was, as always, every time you guys come, I learn a lot. So I much appreciate it. And thank you, Katie.
Yeah,
and thank you, Dr. O'Toole.
No problem. My pleasure.
Lots of information for all the ladies watching. And also, I think it's just as important for men as well. You have sisters, mothers, wives, friends that are at risk. And so please share this information and get checked and don't let it go. And of course, we will post after this show is over how you can get in touch with O'Toole Plastic Surgery, how you can get in touch with all the different resources that we talked about today. So everyone stay healthy, and we'll see you back here tomorrow morning on Liz Live, 11 a.m. Thanks, everybody.
See you guys.
Bye-bye.